So I have no disclosures. So over the past 20 years, many surgical procedures that used to require admission are increasingly being done on an outpatient basis. This is due to a development of an ACE recovery after surgery pathways, advances in anesthesia techniques, and also advance in minimally invasive techniques and approaches. This has led to the successful implementation of fast track pathways without increasing the risk of surgeries. Advantages of day case surgery are shorter length of stay, early mobilization, lower initial postoperative pain, lower risk of postoperative infections, and most important, an increased overall patient satisfaction and decreased institutional costs and decreased use of beds. So there are abundant surgical procedures that for which same-day admissions are, sorry, same-day discharge is already well established. This is basically incisional inguinal hernia repairs, laparoscopic cholecystectomy, tubal ligation, diagnostic laparoscopy, and Nissen fundoplication. More recently, these bariatric procedures are also shown to be feasible to do as on an outpatient basis. So our objective was to assess the safety and feasibility of same-day discharge for complex benign hiatal surgeries. So we took all the patients undergoing elective laparoscopic hiatal surgeries between April 2011 to December 2016 by the Division of Thoracic Surgery at McGill University Health Center. We include paraesophageal hernia repairs, heteromyotomies with or without a resection of epiphrenic diverticulum, and Nissen fundoplications. We decided to exclude emergency cases, so we took 261 patients, and then we stratified based on the preoperative disposition plan in inpatient or day case. Day case were the patients who were planned to be discharged the same calendar day in which the surgery was performed. And then we classify in successful day case unplanned admission. Preoperative assessment and postoperative follow-up are cornerstone of the concept of day case surgery. So all in our hospital, all patients were assessed preoperatively by the surgical team and also by an anesthesiologist and a specialized nurse. A dedicated upper GI nurse follows the patient by phone within 48 hours after surgery, and we schedule a follow-up appointment 3 to 4 weeks after surgery. So these are the criteria we use for same-day discharge. It's basically the same criteria we use for other procedures as an outpatient basis. It is normal vital signs for 2 hours, adequate pain control, no nausea, avoiding urine, tolerating oral fluids, oriented, able to mobilize safely, and accompanied by a caregiver. Our primary outcomes were unplanned admissions and readmissions. We did a multivariate logistic regression after comparing the two groups, and we used a p-value of 0.05 as a cutoff. These are the characteristics of our cohort. We, as I said, we had 261 patients, 98 of which were planned as a day case. 60% of our patients were female, and the vast majority of our patients had at least one comorbidity, being classified as ASA class 2 or greater, like 90% of them. In our cohort, 20 patients, this is around 8% of them, had revisional surgeries. And the only difference we saw in patient demographic information was the age at surgery. This figure shows the sustained increase in the proportion of cases planned as a day surgery. Before 2013, around 10% of them were planned as day case, and was increasing till 2016, while more than 2/3 of them were planned as a day case. The distribution of procedures performed is as it shows. We have 144 patients who had paraesophageal hernia repairs. Most of them, like more than 90% of them, had type 3 and 4 hernias. We have heleromyotomies in around 100 patients, and 9 of them had associated diverticulectomy, and 44 patients who had fundoplications. Around 50% of them had also an associated type 1 hiatal hernia. We found differences in the proportion of paraesophageal hernia repairs, and the surgery started a.m. The length of surgery was shorter for planned as day case group, and the length of stay, of course, was shorter. These are the outcomes. The only difference was the postoperative complications, which are lower in the planned as day case group. This is expectable considering that the less complicated cases were selected for planned as day case, especially in the beginning of our series. Readmission, it's important to notice also that readmissions, emergency room visits, and reoperation within 30 days were the same without any difference between the two groups. When comparing successful day case with the unplanned admissions, we found that postoperative complication was the only difference. And if comparing the outcomes, the readmission, urgent consultation, and reoperation within 30 days was exactly the same. The main causes for unplanned admissions were basically patient preference in 4, uncontrolled pain in 3, and observation after intraoperative complication. These are 3 patients out of 7 who had an intraoperative complication in this group who were observed for gastric perforations who were primarily repaired, and those are 2 patients, and 1 patient had a bleeding after a splenic laceration that didn't require any splenectomy. The 3 of them were discharged post day 1. We perform also a multivariate logistic regression, and we identify the factors who might be predictors of failure or unplanned admissions. And we found that the female gender, intraoperative complication, postoperative complication, and the procedure performance afternoon were significant. So, as a conclusion, we can say that same-day discharge is safe and feasible for advanced laparoscopic benign hiatal surgery, including complex and regional cases, with excellent clinical outcomes. Thank you.
Any questions?
Ralph A. Seattle. Thank you. Very nice effort, and I think Canadians may be different than U.S. But specifically, I'm interested in the paraesophageal hernia group and your rate of nausea, and also whether your numbers for unplanned admissions included those who had surgery the same day and then were admitted directly from your unit, and other silly questions like Foley catheter use and so forth. We've had struggle, especially with the paraesophageals, getting them home even earlier the following day. So I'm surprised at these results.
Well, we don't use a Foley catheter routinely. We have 2 patients who stay overnight because of urine retention. Sorry, what was the other question? Oh, nausea and vomit. Out of the patient who required unplanned admission, 3 of them was because of nausea. On the others, we don't. Well, this is a retrospective analysis, so we don't have for each of them that data. In our pathway, they have to have good oral tolerance to be discharged. So the vomit and nausea rate is pretty low.
A quick question, and that is, our biggest fear is people developing nausea and vomiting post-op. and it doesn't always happen in the postoperative care unit. It often will happen overnight. So do you send them home with anti-nauseants and make it very clear to them if they vomit, they need to come back for evaluation?
Yeah. Yeah, and 5% of them actually come back for reflux and nausea and vomit. They also have the phone number of our unit, and they call us overnight if they need something. But it actually doesn't happen very often.
Okay. Thank you so much.
Thank you.